guys don't have to fill that part out either.
Alright guys, last lecture before lunch. I'm going to be talking to you about rehab considerations for bone stress injuries and runners. So some objectives for you today is looking at high versus low risk stress injuries and understanding their impact on rehab progression. Being able to perform a thorough evaluation of a runner, screening for risk factors, and recognizing impairments that can contribute to these injuries. And then lastly, understanding of progression through rehab, addressing these impairments that you find in your exam. So some facts on bone stress injuries in runners. Lower limb stress fractures account for 80 to 90% of all stress fractures and are very common in runners. Between 1 and 2/3 of competitive cross-country and track and field. Sorry, I'll talk louder. Between 1 and 2/3 of competitive cross-country and long-distance runners have a history of BSI, and 50% of track and field athletes report a history of bone stress injuries on more than one occasion. In running sports alone, stress fractures may account for up to 31% of all injuries, and female athletes are a lot more likely, 1.5 to 3.5%, or more times likely to sustain a stress fracture than a male athlete. Specifically in distance runners, they have a greater risk of developing long bone stress injuries because of their heel strike gait pattern that's more common. And then sprinters have more prone to bone stress injuries in the tarsals and the metatarsals because they more commonly strike with their forefoot. So before we go on, let's define what a bone stress injury is. It's the inability of the bone to withstand repetitive mechanical loading, and it results in structural fatigue and localized bone pain and tenderness. So the bone stress injuries are run along a continuum that you can kind of see on the bottom. So they start with a stress reaction, which is a bone inflammation seen on the MRI and a possible microfracture on imaging. They can progress to stress fractures, which is actual cortical disruption of the bone, and then ultimately progress to bone fracture. There's two kinds of stress fractures out there. There's insufficiency fractures, which is actually normal stresses applied to an abnormal bone, so what we think about with osteoporotic bones or weaker bones. And then there's fatigue fractures, which is what we're going to focus on today. So those will be when abnormal stresses are applied to a normal bone. So if there's overuse injuries, that's where we see them. So this is in an article by Warren et al. It's the proposed pathophysiology of the bone stress injury continuum. So with running, you get a lot of bone loading, which leads to bone strain and deformation that's influenced by skeletal factors and the person's makeup and their running form. Depending on the magnitude of this strain and the individual's threshold, this can lead to damage or no damage. Bone damage is actually a natural and useful phenomenon because it leads to a stimulus for targeted remodeling of the bones. But that's when you're getting enough bone damage and the repair is occurring at the same rate. That's ultimately when they become asymptomatic, which you can see on the left side of that chart. On the right side is when you'll get overuse injuries where you're getting more bone loading that can repair itself. So then you're going to go down the pathology continuum of stress reaction, stress fracture, and ultimately bone fractures. So why do these injuries happen? There's a good article by Davis and Fruchel that kind of showed this image. So every individual has a threshold for these injuries, and it's influenced by multiple factors. Dosage, mechanics, and structure. So the structure of a person, their static alignment, their foot type, basically how their bones have grown and developed. The mechanics are the forces, their running form, things like that. And then dosage is how much they're running, how many mileage they're doing, what kind of surface they're running on, things like that. So all of those can contribute to injury. If there's any abnormalities in one of these or multiple of these, they're just going to be an increased risk to get a stress fracture. So like I said, every individual has their own threshold, and the exact location of a bone stress injury is going to depend on the individual themselves, how they load their skeleton, how they're built. So it's different for every person, very individualized. With that being said, half of bone stress injuries in long-distance runners occur in the tibia, with the majority of the other bone stress injuries occurring in the femur, the fibula, the calcaneus, the metatarsals, and the tarsals. And they can occur in the pelvis or the lumbar spine as well, but those are a little bit less common. So there is a ton of risk factors out there in the literature. Like I said, it's kind of individualized based on the person's running form and everything. So that's why there's a ton out there. The three strongest I found are history of a previous stress fracture, female gender, and then a low BMI under 19. I want to point out that we can't really modify a lot of these, or these three in general. So we want to try and focus on risk factors that we can modify. So some general categories of risk factors, we have intrinsic and extrinsic. Intrinsic, there's genetics, diet and nutrition, hormones, bone diseases, and medications that the patient may be taking. And then for extrinsic, there's things that we can change a little bit more. So the biomechanical factors, training factors, muscle strength and endurance, training surface, and then their shoes or inserts that they may be wearing. So like I said, there's a ton of risk factors out there in the literature, and this is a pretty busy slide. But I want to point out the red boxes, because those are things that we, as rehab specialists, can try and evaluate. So take gastrocnemius or other tight muscles, hip adduction and knee valgus, which is a big component of rehab. Decreased hip abductor strength, decreased flexibility in the forefoot, and high ground reaction forces. Some other ones on here that we can educate on, but can't really change unless the runner makes that change themselves, is training in old shoes, year-round running, training intensity increases, and then the female athlete triad, which we'll get into all of these further through the lecture. So how is a bone stress injury diagnosed? It's usually based on a history, clinical exam, and imaging. X-ray is typically the first line of choice by a physician, but up to 85% of stress fractures won't be identified on an X-ray initially, because it takes about 3 weeks for that cortical disruption to actually show. So there can be a lot of false negatives on that X-ray. MRI is typically the best option and the modality of choice. It's the most sensitive and specific. A review by Wright et al. Discussed that bone scan and CT scans can also be used, but they have less or poorer sensitivity and specificity than MRI itself. They also expose you to higher radiation, so that's why they chose the MRI as the best. So Wright actually put out this imaging algorithm, and they kind of show that X-ray, again, is that first line of choice. If it's negative and in a high-risk site, then they propose that you automatically go to that MRI. That's because limited diagnosis or prolonged diagnosis of those high-risk sites can actually lead to prolonged problems later on. And then if that MRI is positive, then you'll go treat it like a stress fracture. If it's negative, then or inconclusive, then they would go to that CT scan. So like I mentioned before, there's high and low risk bone stress injuries. So low risk bone stress injuries are the ones that we more commonly see, and the majority of these injuries are low risk. They have a favorable natural history, and there's a low risk of complications, and they usually respond to conservative care. High-risk bone stress injuries, on the other hand, kind of present some treatment challenges. These high-risk sites share a characteristic region of high tensile load and low blood flow that makes them prone to poor healing. There's a higher risk of non-union or delayed union in these fractures, and sometimes they will require surgery as well. So that's why it's harder to diagnose them, but more important that we try to diagnose them as fast as we can. So there is some further classifications that are out there. So besides high and low risk, there's high and low grade. So as you can see on this chart, grades 1 and 2 will be considered low grade. So there's not a lot of cortical disruption, and there's not a lot of swelling seen on imaging in these grades, whereas high grade would be 3 and 4 on this chart. There's more swelling, and you can actually see a fracture in grade 4. So why does this pertain to us? We want to know what the grade and what the risk factor is, because low grade, low risk is going to have the most optimal recovery time. And we can just give our patient a prognosis and explain that to them when we know what they are. So breaking it down into body parts, the hip and pelvis have, these are kind of less common, they're more proximal stress fractures. So in the femur, it's 6.6%, and the pelvis, 1.6% of all stress fractures. The most common sites are the femoral shaft, the lesser trochanteric, intertrochanteric region, and the pubic rami. And then diagnosis of a sacral or pelvic or femoral stress fracture can be difficult because there's a lot going on in that area, and the signs and symptoms often aren't as clear as lower down the leg. So high risk in this area is the femoral neck because of that low blood flow and high tensile load in that area. And then low risk would be the femoral shaft or the pelvis. And diagnosis in this area can often take up to like 14 weeks to diagnose. So it is a problem that they're trying to work on with that imaging algorithm and things like that. In the lower leg, everyone's heard of shin splints. It's a very common injury, and this is actually the most common area that you will get stress fractures. A quarter to a half of all stress fractures occur in the tibia. Most of them are posterior, 75%, 19% are medially, and 6% are anterior. And then they also have fibular stress fractures as well. That's 5%, 5 to 12% of all stress fractures. And it's more common in the distal 1/3 of the fibula, especially in long distance runners. Jumpers and sprinters may get them more proximally on the fibula because of the higher stresses that they're putting on. In this, the lower leg compartment, the high-risk stress fractures would be the anterior tibia or the medial malleolus, and low risk would be posterior medial tibia, fibula, and the lateral malleolus. And then finally in the foot and ankle, the tarsals and the metatarsals are the biggest ones that we focus on. So the tarsals have a 17 to 20% of all stress fractures, and the metatarsals are 16 to 20%. The most common tarsal is the navicular bone, and that's usually seen in sprinters. And then the most common metatarsals are the second through the third metatarsal shafts. High risk in this area would be the talus, the navicular, the base of the second metatarsal, the proximal fifth metatarsal, and the sesamoid bones. And then low risk in this area would be calcaneus or the diaphysis of the second through the fourth metatarsals. So taking all this information, how can we apply it to an exam? So we want to think about, like I said, how the female gender, history of previous stress fracture, and a low BMI are all the highest risk factors for a stress fracture. So we want to ask about that. We want to see if they've had any recent change in their running surface or their running intensity, running form, or their shoes that they're running in. Any increase in their mileage, if they've started any new activities outside of running as well, that can contribute to the increased stress they're putting through their legs. Have they had a prior history of stress fracture? How is their overall general health? Are they eating healthy? Are they eating enough to sustain their needs? Are they taking any medications that could predispose them to a risk of stress fracture? If they're female, have they had any changes in their menstruation? And do they have a history of osteoporosis in their family? So all things we want to think about and kind of screen for in our subjective. Typically, a patient is going to report a history consistent with overuse with one of these injuries. They'll have a gradual onset of activity-related pain, and typically when it first starts along that continuum of the stress reaction, they're only going to get pain with running, and it may be in a certain part of the running cycle or after a couple minutes of running or a certain time of running. And typically once they start running, it doesn't go away until they stop, and then they often kind of ignore it because they won't get pain outside of running. It can progress to where they're getting pain with daily activities, where their running may be inhibited, and then when they're even getting resting pain or pain just with walking. So that we know we're a little bit more progressed down that continuum. They often can point to a localized spot, especially with a foot bone stress injury or in the lower leg where the bones are a little bit more palpable. And the pain can also be diffuse, especially more proximally in the pelvic region. So moving on to your objective portion of the exam, the most obvious feature of a bone stress injury is localized tenderness to palpation, especially in the lower bones where you can palpate in the tibia, the fibula, and the metatarsals. Like I mentioned before, the deeper bones, like the femur on the spine, where you can't really palpate as well, they may have a more diffuse tenderness to palpation or diffuse pain as well. So to provoke those symptoms, you may have to do something like a fulcrum test that's shown in the picture on the left. The favor, which is shown on the picture on the right, hopping or range of motion, especially for those sacral or pelvic stress fractures. They may be limited or have painful hip range of motion. You may also see some pain and weight bearing depending on how far along the continuum they've progressed. And sometimes you'll see a redness, swelling, or warmth that may be present. So in your objective exam, just like any other injury, you're going to look at static alignment. You want to look at what their posture is, how they're going through a line, looking for symmetry in their legs, their hips, their knees, and ankles, what kind of foot type they have as well. You're going to look at their strengths and their flexibility, and then you want to look at their lower extremity mechanics, doing something functional that's pain-free for them. So whether that be walking, squatting, single leg squatting, lunging, something like that, a functional activity that you can kind of see their mechanics a little bit. And like I said before, you're going to take all of that information from your subjective and objective exam and kind of educate your patient on their prognosis. So if they're low risk and low grade, they have an average return to sport of about 8 to 9 weeks. If they have a low risk, high grade, or any high risk injury, they have an average return to sport of about 20 weeks. So it's just something that they can know and be prepared for, that you can educate on. It's important to note here, though, that there's kind of a great variability in return to running between individuals, even with those that have the same category of injury. So it's not, we don't want to treat just what the imaging says. We want to treat the patient themselves and pay attention to their symptoms and their mechanics and everything like that. So out there in the literature, there was this 2-phase protocol that kept coming up. So that's what I decided to focus on here. In phase 1, the main goal is pain-free during and after ADLs. So pain is your guiding factor. If they're doing something that's causing them pain, that means the bone's being stressed too much, and we need to alter that. So that may be modifying their ambulation at first until they are pain-free with that ambulation. But ultimately, we want to get them weight-bearing as tolerated as soon as we can to progress them. In this phase, there's minimal impact running, but minimal impact activity, but no running. So we want to maintain their cardiovascular fitness, especially in those long distance runners, because they'll start to lose it pretty quickly. So we can do things like the bike and the elliptical, swimming, pool running, or anti-gravity treadmill to help maintain that cardiovascular fitness. So these are 2 big things that popped up in the literature. Looking along this area of sport specificity, these are the 2 cross-training options that really target running the best and are the most sport specific. Unfortunately, these are probably the least available out of those 2. So if we have access to these are great. If not, then we have to come up with something else, either use the bike or elliptical, doing some kind of workout on that. But there is some studies that show that deep water running helps to maintain that cardiovascular fitness. There's limited published articles on anti-gravity treadmill, but typically you'll start at like a 50 to 65% body weight and then progress weekly from there up until they're about 85 to 90%. And then you can start them on a running program on land. The good thing about both of these is that you can do typical workouts and things like that, like fartleks or tempos or anything, to kind of maintain that cardiovascular fitness as well. So they're maintaining that fitness. What I want to point out with the deep water running is that a lot of studies have shown that have done that, that you need to do kind of a higher perceived rate of exertion in the water as opposed to land-based workouts, because it's a little bit, you're losing the land-based workout, so you need to, challenge your cardiovascular system a little harder in there. So phase 2 can begin 10 to 14 days after pain-free with ambulation and cross-training. You want to focus on a progressive return to full running, And then also target muscular endurance training, flexibility, core strength, and balance, and begin that running progression in this phase. So talking about return to running, you want to begin with 30 to 50% of your pre-injury mileage, and then progress by the 10% rule. So no more than a 10% increase per week in mileage or intensity. You're going to start off slower, less intense running until you work your way up the miles, and then you can begin increasing the intensity or duration and distances. They also recommend starting on a softer surface as well. If you can't do that, then you really want to monitor starting at a slower pace as opposed to going faster too soon. And of course, as you return to run, you're going to monitor for your pain and any signs and symptoms that your stress factor is returning. So there's a lot of running protocols out there, but not any truly great ones that I found. So this is one I chose to show you. It's for anyone that doesn't have access to those deep water running or anti-gravity treadmill, and those that are non-elite runners. So as you can see, they start off the first week just running 3 days and no more than 15 minutes, and they take a day or two in between each. They propose that on the days in between you can continue that cross training as well to keep maintaining that fitness. Week 2, they do the same, they just increase the mileage or the distance a little bit, and then by weeks 3 and 4, you're progressing a little bit more. So this return to running phase, they propose is over 4 to 6 weeks, but it is going to depend on the individual, and it's going to be a little bit specific to your patient, depending on how much distance they need to get back to and how much speed they need to get back. So some other things to address in phase 2 are strengthening of the lower limb and hip, endurance training, core training, balance, flexibility, and heat retraining as well. So we'll kind of go through all of these. So the ultimate goal of strengthening is to improve the bone mineral density in runners, because a lot of times they'll get stress fractures from not having strong bones. There is support that general strength training can help to improve the running economy as well. Johnson et al. Compared a 10-week training program with resistance training and endurance training to just a group that did endurance training, and found an improvement in running economy in those that added that resistance training component. Another article that looked at that, I took their exercises just to show you. So they kind of target a lot of the muscles that running requires. So a lot in your glutes and your hamstrings, as well as your quads and calves. So these are just some exercise examples. So there is some evidence out there that shows just general strengthening without the neuromuscular control component doesn't really help improve your running form. So we need that neuromuscular control component to help decrease, especially that knee valgus, thigh adduction motion that usually or commonly it happens. So some strengthening ideas to help with that. On the picture on the left, you can have your patients do a single leg squat using a knee valgus control, or have them do any kind of squatting or lunging or jumping in a mirror to help kind of control and for them to see, doing them to try and prevent that knee valgus. Then you can do just general strengthening of muscles that they may be weak in, such as single leg heel raises or any kind of heel raises, things like that. Moving on to endurance training, so we want to train the muscles that especially get fatigued during running, which often happen up at your hip. So these endurance fatigue muscles can impact force. If they get tired, then you're going to put more stress through the bones, and that can predispose you to risk putting stress through the bones itself. So commonly we want to target those external rotators in your abductors and your hips. So some ways I like to do that are using resistance band or monster walks and side steps, and doing side bridges or just regular hip abduction, external rotation, things like that. But you want to think about running, long distance runners especially are going to run a long time. So they need to do a high repetitions of these exercises. Moving on to your core. So again, it's pretty common to see the valgus, hip drop, or thigh adduction motions. So we want to target these areas as well. So just generally targeting your core, you can do planks, side planks. You can do steamboats or kicks in 3 directions, preventing any hip drop from happening, either cueing or showing them in the mirror how their pelvis may be dropping. One of my favorite exercises to do is a bridging with a leg extension, because that way your patient can kind of see their hip drop and kind of can prevent it by seeing it themselves. Any type of balance and proprioception is going to strengthen their intrinsic and extrinsic foot muscles especially. This is really important, especially for cross country or those that run on the trail, to help balance any changes that they might encounter there. So you can do this with any dynamic surface that you have, such as AirX, BOSUs, Dynadiscs, things like that. And you can incorporate any lower extremity or upper extremity movements to challenge them. You can even do some more running specific, like jumping onto a BOSU and having them hold, to try and prevent those changes and maintain a good running form as well. Lastly, if you think about running, it's just a straight plane motion. So often your sagittal muscles are going to be the tightest. So you want to look at the flexibility of the gasstrap, your anterior tib, hip flexors, quads, and hamstrings, and target any limitations that you may find. You can also look if they especially do have an injury in their forefoot, look at the flexibility in their joints themselves as well. Gait retraining is another important component, but luckily we have our entire lab later to talk about that. I'm going to leave that for a minute. But a big component of that is just going to be reducing the ground reaction forces, which was on that risk factor slide at the beginning. So some general other treatment ideas. There's been some research out there that shows that prior participation in ball sports can actually lead to a decreased risk of stress fractures later in life. So kids that have played ball sports in the past have less risk of an injury, of a stress fracture injury. So that may be a component that we want to think about, especially like I said, running is just a straight plane movement. So if we incorporate some side to side or jumping, things like that, that may help increase their bone strength and increase their overall strength. So some ways we can do that is adding box jumps or line jumps or cone jump overs, forward and backwards, but also side to side. You can add some BOSU lateral jumps to get both that dynamic ability and also the proprioception. We can also add some cutting, twisting, and turning motions as well through box drills or assisted gait in all 4 directions. That can just increase their strength and agility in all directions, not just forward. Going back to a high-risk injury, so like I said before, these are a little more complex to treat. They often have a longer recovery time and then prolonged activity modification. They may be non-weight bearing if they're going conservative care, or they may require surgery as well. After they see that they have cortical bridging, then we'll go in through the whole phase 1, phase 2 protocol as well and treat them the same way. Based on that, it's just going to be a prolonged care. So I wanted to show you this chart. This is a recent article that came out talking about management of high-risk bone stress injuries. So it has on the left side all the high-risk sites and their percentages or how common they are in the common sports, most of which include running. And I wanted to point out specifically that there is a couple diagnoses that require just surgical referral. They don't even try conservative care. So any stress fracture to the femoral neck specifically, or any displaced stress fracture, they will go directly to surgery. A few other areas, like I mentioned before, that we can educate on, but we can't really change unless the athlete changes themselves. Our shoes, female athlete triad, and nutrition. So shoes, they recommend replacing every 300 to 500 miles, or at least every 6 months. That, again, is going to depend on how much and how often the runner is running. So they may need to change them every 2 to 3 months, depending if they're doing that many miles in that short amount of time. The female athlete triad is becoming a bigger and bigger thing to talk about, especially in this population. It's very common, you'll see in your female long distance runners especially. Typically they're not getting enough energy availability, which is affecting their bone density, causing them to have stress fractures or stress reactions, and they may be getting abnormal menstruation periods as well. So this insufficient dietary intake decreases that ability of the bone to resist load and impairs its ability to repair itself, which leads to that bone stress injury. So we want to screen for this and educate them on it, and if we think they need to see and talk to someone about it, we can refer out. Lastly, with nutrition, it's been shown that higher levels of calcium and vitamin D supplementation may be a component of stress fracture prevention. So again, this is something that we can screen and ask for, see if we think they're getting enough calcium and vitamin D in their diet, and if not, or if we think they need to talk to someone about it, we can refer to a nutritionist as well. There is a couple other treatments out there. Biophosphonates are usually prescribed for osteoporotic treatment to prevent bone loss, but it's not supported by randomized control trials in this population. They have low intensity pulse ultrasound and electrical stimulation as well, which may increase the rate of bone healing in acute fractures, but again, in this population of stress fractures, there's not really good studies about it. It's pretty unknown what the effect of these treatments would do. So I just wanted to acknowledge that we had a bone stress injury outcome group here, and that's where a lot of my information came from, and then I built upon that. I just wanted to give them some credit. Any questions? So if you could fill out both those forms for Minnie and I, that would be awesome. If we can put them over there, maybe that would probably be a great place to put them. Thanks.
We're a little ahead of schedule. I'm sure you guys aren't supposed to, but you guys want to just keep an hour lunch and then maybe get done a little bit early? You cool with that? So we'll do, the labs will start at noon. Like I said, it's across the street. Give me the address. Do that too, but. And so I have some maps back there if you guys want those for some surrounding restaurants. So there's a lot within a mile from here, so it should be able to find something.